Good afternoon, gentlemen. Thank you for coming to the Republican Party panel discussion put on by Jennifer Carnahan and company. You can't hear? How about now? Okay, good. Great. We have an interesting lineup here for you today as far as if healthcare is of a concern, and there couldn't be anything more important or intimate to any of us than the quality of our healthcare. This is, I think, an important issue for the country as well, and we've been paying attention to what's been going on in Washington. It's absolutely an essential thing that we get right as a country. We have an all-star cast for you here, and I'm going to ask them to get started. We'll start with Matt Dean. And Senator Benson is on her way as well. So we'll get started just via that way. We'll be having some questions and answers as well coming up, but hang on to those all at once, and then we'll get to the questions and answers for the group. Okay? Thanks. Matt?
Thank you. My name is Matt Dean, and I serve in the Minnesota Legislature in the House. I was first elected in 2004. I've served since 2005. Both as majority leader as well as chairman of the Health and Human Services Finance Committee. It's a very important topic that we're talking about for access for health care for all Minnesotans, and also how we take care of people who are some of our most vulnerable Minnesotans, and how we do that really reflects not just how we're doing as a state government, but how we're doing as a people. And we have a moral obligation to do so, and I think in Minnesota, we do a great job. We have the best health care, not just in the country, but in the world, and we want to make sure that we hang on to that. So that's something that I take very seriously, and we have the best health care in the country, but are we going to be able to keep it, and how are we going to be able to provide access to more people? Middle-class Minnesota is in a vice right now. They pay more and more to get less and less, while they see others pay less and less to get more and more, and nowhere is that more true than in healthcare. So if we don't really address this crisis, we're going to be in a world of hurt. So it's something that I focus on, and something that I've really prioritized with other members of the House. Two on the committee are with me today. I'm very proud of all of the work that they have done in the last session, and I'm sure they'll chat more about that. But it's great to be with you today. Great to talk about this issue. I'd like to thank Chairwoman Carnahan for talking about health care and really bringing it up not just as a political issue, but it's something that we need to solve and we need to get right. Thanks so much.
Thanks, Matt. Bob? Dr. Bob Geist.
Hi, hello, under there. I'm Bob Geist. I'm a former plumber. Am I supposed to?
Just introduce yourself. Introduce yourself.
Okay. So I'll talk to you later. I've got my teleprompter with me.
Okay. Yeah, I'm State Rep Glenn Gruenhagen from House District 18B. That's McLeod, Sibley County. So I come from a rural area which has been particularly hit hard with higher premiums and higher deductibles and smaller networks because of the ACA. But I think all of us, and I don't want to repeat anything that's been said, but obviously healthcare and its access is a critical issue for all of us, regardless of our background, our political affiliation, or whatever. What we have to understand, though, is that the demographics in our country are changing, okay? And this is going to affect everything, especially healthcare. And what I mean by that is we've had a productive middle class dominated by the baby boomers. Those baby boomers, along with technological productivity, have had a tremendous impact positively on our economy and our tax revenues. But that's about to change, okay? The baby boomers, about 77 million, are going to retire. There's a smaller number of people behind them, and the baby boomers have longer life expectancies than their parents and their grandparents, and they're going to expect more health care. So this is going to cause a lot of problems nationally and also in our state. Give you an example, just with Medicaid in our state, this past biennium budget, our total spending in state government in our budget, biennium budget, 2-year budget, went up about 9 to 9.5%. The private sector economy in 2016 and projected in 2017 is going to grow at about 3%. So government's growing at 9%, And your private sector, which is paying the bills, is growing at 3%. I don't know about you, but I can't do that in my personal finances. So we have to reform Medicaid in this state. 5% of the 9% growth, or about $2 billion, was due to Medicaid increase in the state. And according to our former state demographer, Tom Gillespie, who's retired now, if we don't get the cost of government health care, Medicaid, under control in our state, there will be no additional money for roads or bridges, K-12, or higher ed. That's not my opinion. That's the opinion of Tom Gillespie, our former state demographer. And it's proving to be true. So we have to reform Medicaid. We have to repeal Obamacare at the national level and block grant Medicaid down to the 50 states and allow them to experiment on how to meet the needs of the people in our state, especially the most vulnerable. Thank you.
My name is Representative Bob Loon, and I represent the Shakopee area. And I come from an insurance background with 35 years of selling insurance, 31 years of teaching insurance. And what I bring to the table, I sit on Representative Dean's committee, Health and Human Services Finance, and to talk about the white elephant in the room, which has to do with cost shifting. Representative Gruenhagen talked about we have to reduce the cost of public health care. I want to clarify what that means. What each particular item costs is well within a tolerance range. We've got very low reimbursement rates that are causing other problems. The obstacle we have is how many people are considered eligible for assistance, people that are able-bodied. The cost-shifting little secret that goes on allows insurance companies on their books to contend that when they treat someone on medical assistance at a low reimbursement rate, they can declare a loss, shift that over, and add that on to what they bill someone who comes in with insurance coverage or a private payer who has means. I get concerned about that because it's very easy to make that confusing and hard to follow. My grandpa Loonan told me when I was in my teens that, there's a reason churches are well lit and bars are not. It's because of what's going on. And I think there's some nefarious things going on that are allowed to go on because they've made it so hard to understand. We're to a point now in healthcare where you aren't allowed to find out what something's going to cost before you evoke the coverage. And I think that's what a lot of the conversations are going to be. The ultimate solution for healthcare is going to be the work of consumers. I feel we as legislators need to facilitate consumers being able to bring the market in, to shop when they evoke healthcare.
I'm Dr. Lee Beecher. I'm president of a group called Minnesota Physician Patient Alliance. We've been in existence for 20 years, and I'm a retired psychiatrist. I'm president of the group now. What we're concerned about is how to look at the professional role with the patient, and that means where the money is going, and as Representative Loonan just indicated, how does the patient control what happens? That's going to be the emphasis of my talk today.
Hi, State Senator Michelle Benson. I am the Senate counterpart to Representative Dean, Chair of the Health, Human Services, Finance, and Policy Committee. I ran for office because of the Affordable Care Act. I knew how consumers would react. I knew what would happen in the market, and we need to get consumers back engaged in the market. Look at what Indiana has done with their Healthy Indiana plan. They reform Medicaid so that we don't presume that poor people are stupid. We presume that poor people can make good healthcare choices and can save money, and we reward them for making good choices and saving money. And long term, it helps them to be more independent. So when you're talking about public health policy, moving everyone to a greater level of independence, giving people more options, more choices instead of fewer. Right now, we're a little hamstrung because there's no action happening at the federal level, and every time we think it's moving, it gets stopped. And so we just keep watching Washington. We're not going to wait. We're going to put good ideas forward. Everybody on this panel has good ideas to bring forward, and we're going to hear some of those today, and then we're going to move some of them in the legislature, see if we can get them past the governor.
I'm Heidi Matson. I'm an insurance agent. I've been an insurance agent for 25 years. I own my own agency in Blaine, Minnesota. I am also a past president of the Minnesota Association of Health Underwriters, which is a professional association of health insurance brokers. I'm currently their executive director, and I'm also chair of the Agents Coalition for Healthcare Reform. I am MNSure certified, and I work with MNSure on a regular basis. I also serve on their Health Industry Advisory Committee, trying to bring ideas to the MNSure board.
Just so you know, the Republican Party of Minnesota has been involved via a healthcare task force that we have here. Most here are on that healthcare task force, plus about a dozen or so more, since 1992. The health savings account idea that is now the gold standard of the marketplace came from the Republican Party and came from this task force back to 1990 as well. We have multiple issues going on, so we have a multifaceted task force made up of physicians. So we have two presented here for you: legislators, insurance agents, and attorneys. So it's a very complex overall issue. But one thing that we all know for sure is that premiums in individual coverages and premiums in small group have skyrocketed since the Affordable Care Act was passed and was implemented. I'd like to start with Heidi Massa to talk a little bit about some of the details about why insurance premiums have spiked like they have in both the individual and small group markets since the passage of the ACA. Heidi?
So in Minnesota, we had a very well-performing insurance market prior to the Affordable Care Act. But some of the provisions in the Act changed the way our market worked. We were very forward-thinking, and we had a program called the Minnesota Comprehensive Health Association. And what that program did was take those that had chronic long-term health conditions or even short-term chronic health conditions, and it moved them into a separate pool that was managed and shared by all of the health plans in Minnesota, along with state participation. And we eliminated that program with the Affordable Care Act, which meant that all of these high-risk individuals, higher claim individuals, now joined predominantly the individual health insurance market. And so a market that had been performing very well was suddenly, in 1 year, influx with about 100,000 people that had a lot of health insurance claims. And the result of that has just driven our rates year after year higher and higher. The very first year we had 50% rate increases. The following year, 40% rate increases. Last year, 30% rate increases. And now this year we're talking about rate increases again. But there's still a lot of uncertainty on what our rates are actually going to be starting in January. And that is because Minnesota has created a new reinsurance pool that's going to operate a little bit like the MCHA program used to work, but this one is going to be behind the scenes. So for those consumers that would have normally qualified for the MCHA program, they would be part of a reinsurance pool, but behind the scenes. And we think that this is going to work really well for consumers. But there's uncertainty because that program has not been approved yet. It requires a waiver from CMS, which is the Center for Medicare Services, which handles all of those ACA exemptions. And it's just kind of stalled. Nothing's happening with that waiver. And so right now our health plans have filed rates with the waiver, which would remain rather stable. Without the waiver, they're going to increase again. With the small employer market, one of the things that happened with the implementation of the Affordable Care Act is that we eliminated the ability for the health plans to give a reward to the groups that were healthy. And then there was also on the other side a penalty to the groups that were unhealthy. But they were all guaranteed coverage. Everybody got coverage, but there could be some differences in rates based on health. But when you take away that incentive for healthy behavior, what happens is that you start getting unhealthy behavior, and the rates are increasing in the group market as well. And so what happened in the initial years of the Affordable Care Act is that instead of meeting in the middle, you take the higher cost groups and the lower cost groups, and you'd naturally think they'd meet in the middle. They didn't. They met on the higher end. And because that group is larger, there's a little more stability to that market. But again, we're going to see increases this year, of around 10%. And that after time, it becomes unsustainable. So some of the tools that have been used by consumers is to go with higher deductibles. And now those are starting to become the norm, where individuals and families will have $6,000 to $7,000 deductibles, which starts to not feel very much like insurance anymore. It starts to feel like a plan that you don't ever want to use. And so what happens is people put off care because of that reason.
One thing we don't hear much about is the impact of overregulation in the doctor's office. So I would like to ask Dr. Geist and Dr. Beecher to tag team this and talk about what goes on because of regulations in the doctor's office that affects the quality of care.
I'm Dr. Bob Geist. I practiced in St. Paul for about 40 years, and now I'm retired. Since I'm a lousy public speaker, I brought my teleprompter along. Thank you if you listen. I can do this in 3 minutes, not the 4 I've been allowed. So here you go. What's happened to Obamacare medical quality, and why have insurance costs exploded when doctors' fees have been fixed for decades? Well, first of all, you have to know that you have the finest, most well-trained medical workforce in history out there with the tools to do the work. They have a covenant to serve their interests of their patients first. But that's going to change. Physicians, the backbone of medicine, have been systematically and speciously lied about, accused of causing cost inflation. They are allegedly driven to avarice by an evil fee-for-service system. You're going to hear that more and more in the next few months and years. Yeah. Is this absurd? Of course it's absurd. Fees are paid for goods and services and have never been accused of driving inflation in any other economic sector. And that's where you buy groceries, shoes, refrigerators, or other professional services. And doctor fees have been systematically fixed low for decades. But false accusations are a slick way to hide decades of HMO cost control failure and to advance corporate control of medicine. That's what you're coming against. Now, what has this got to do with quality in the land of Obamacare? ACO, which are many hospital medical staff provider insurance corporations, are created by Obamacare to cut costs. They are legalized by Obamacare regulations and laws. You can ask me about those later if you like. Laws to pay doctors at the bedside more if they order less care. That's called a bonus opportunity. Or they're to pay them less if they order, in quotes, too much use of corporate money. This is volume pay, and it's also known today as value pay, which of course you're going to hear about incessantly over the next year or more. That's a euphemism to sell the public, you and the politicians behind me, on the proposition that doctors can gain redemption by turning their former fee-for-service avarice into a social good when they produce profits at the bedside as corporate gatekeepers rationing care. You don't want that. So in summary, poor quality Obamacare results. Number one, when a speciously defamed workforce is changed to computer quality checkboxes instead of spending quality time with patients. Number two, when your doctor is forced by Obamacare regulations and law into the role of bedside ACO, HMO corporate gatekeeper, they don't have a choice in it. This is coercion now. Excuse me. And they're paid to ration care, that is the profiteering, masquerading as stewardship of society's scarce resources. That's euphemism. Finally, when Obamacare empowers and protects the corporations instead of families, the result is crony government corporate cartels with collusive price fixing and franchising where the government mandates you buy its cartel partner's expensive insurance product, which you heard a lot about here, and that's the way crony cartels operate. Well, listen, thanks a lot. You have some serious problems ahead if you're a patient. Thank you.
Thanks, Bob. Lee, I'm going to ask you to tag team off of that as well. Any comments to add about the ACOs?
It's a little difficult to hear, and I think what I would like to have is more responses from you about the questions you have. My task was to talk about the American Act that we now have in terms of how it's impacted physicians. It's very important for you to understand the shifts in Minnesota with regard to physician employment. 20 years ago, a majority of doctors were independent or were in clinics that were sponsored by physicians or their own control. Now, hospitals and large clinic systems have bought up the doctors. So how the doctors respond to the ACA and the Accountable Care Organization depends on who employs the doctor. And when you as a patient go to ask your doctor how much something costs, it's very unlikely that the doctor won't know. And if the doctor refers you to the business office won't know, and the business office won't find out, and you won't find out until after the care has been delivered and the bill has been submitted. So the doctors are a bit in the dark about what's going on really with these high-level changes that you've been hearing about and probably straining to understand today. The debate, however, goes on. The Republican Party has taken on the mantle of getting rid of the Affordable Care Act and replacing it with a more consumer-directed approach. It won't abandon the poor. It will not abandon the Medicaid population. So today you're going to hear about some of those alternatives.
Representative Dean, you've indicated you're a key committee chair in the Minnesota House and also that you're running for governor. As a key committee chair for the majority party, what influence might the GOP have over real health insurance, health care reform at the state level? And also, how important is it in the governor's office influencing real reforms at the state level? Can you briefly summarize what was accomplished last session?
Thank you. Well, I can kind of combine both of those questions into one answer, because one thing that Donald Trump has said is that if states can do health care better than the United States or the ACA, we're going to let you do it. And in Minnesota, nobody does health care better than we do. We have the highest quality health care in the country and in the world. We had some of the lowest costs in the country. So we've got the undisputed best value in the country. But something happened. Government got in between you and your doctor, between your hospital and you, and screwed it up. It made it completely unfair so that people who pay more and more get less and less, and people who pay less and less get more and more, and that doesn't make sense long term. So we have to have a plan to fix that in Minnesota, and luckily we've already got great doctors, we've got great hospitals, we've got the people in place for now, but we will not have them for very much longer if we do not act. So I don't care if we need forgiveness or if we need permission, but we're going to do things the Minnesota way again in healthcare, and we're going to start in the legislature and with the governor. And we can do that because we've got the people. And instead of saying, hey, we're going to allow everybody, this is what they wanted us to do, by the way. They wanted us to say, you know, it's illegal not to have health care, so we're going to let you go without health care, and we're going to give you a ticket, you're going to break the law, and we're going to let you rip up that ticket. We're going to turn you into a lawbreaker and then allow legislators to look the other way and let you do that. Does that sound like really meaningful health care reform to you? How about you say to the state, instead of asking me to break the law, why don't you fix it with the federal government, because we had it good and you screwed it up. So that's what we are going to do. Whether we need forgiveness or we need permission, we are going to do things the Minnesota way again. And I've got a plan to do that, and when we are in January of 2018, we're going to take up that mantle and do it. We're going to have that argument and that discussion with the state of Minnesota, and they are going to do all kinds of things, throw all kinds of things at us as we try to do that, but we're going to come back with facts. And I will leave you with this. At least you think that this is a Republican thing. It's not. It's a fact. Okay, this is not a partisan thing. My favorite cartoon is of a guy getting rolled into the emergency room. And there's a fight that's broken out, blocking him from getting into the ER. And it's Democrats and Republicans. And the guy laying on the gurney looks around from his IV and says, "Excuse me, I really don't have time for this right now." Okay, that is the state of Minnesota. That is the country right now. And we're going to have to solve some problems, and we're going to have to deliver some results. That is up to us. If we choose to continue a political debate for our own political good, we can and should expect the punishment that will be coming our way. If we promise and deliver results, we're going to help the American people, we're going to help Minnesotans, and we can also lead the rest of the state, so Minnesota can lead rather than follow in healthcare. And that's where I think we should propose to start.
Thank you, Representative Dean. Senator Benson, you're a key committee chair in the Minnesota Senate. As a key committee chair for the majority party, what influence might the GOP have over real health insurance and healthcare reform at the state level? And follow-up question, what impact did the governor's office have in your ability to make key legislation become law?
Well, as everyone here is aware, Governor Dayton is an advocate for single payer. He's an advocate for more government control in healthcare. Minnesota was the only state that went all in on the Affordable Care Act. We implemented the state exchange, we implemented the basic health plan, we expanded Medicaid, we did it all. And it has impacted our insurance rates more severely than other states in the nation. And it has impacted Minnesotans. I was over at the Senate booth for 2 hours today. The most common question is, what's going to happen to my health care? And these are small business owners, folks. These are farmers. These are people who have done nothing wrong in their life, and they got a 67% increase last year, and they didn't do anything wrong. They made no choices different than the year before, and their costs went up. Members of their family are having to go get jobs at places like Target and Menards so that they can afford their health coverage, or they're going without. It is going to decimate the heart of our economy if we don't get this under control. We took a few steps last year. We gave a 25% rebate to those people who did not qualify for any other form of assistance. And before you get upset because Republicans aren't supposed to do handouts, remember, the people who received those rebates are not eligible to deduct their insurance. Employer coverage is deducted. People who are on public programs pay no taxes on the benefit they receive. And we can't sustain it long term, but it gave them a little breathing room and maybe an opportunity to look for a path out. The second thing we did was put in a market stabilization tool. It's called reinsurance. There are people who disagreed with it. There are people in particular who disagreed with the way we funded it. I understand that, but we had to compromise with the governor and the stakeholders, but we got something in place so that Minnesota's insurance rates are as stable as they have been since the beginning of the Affordable Care Act. We had good market stabilization tools in place, and not through an act of the legislature, not through the signature of a governor, through fiat from Washington, our stabilization went away. So we put it back in place. None of these things are magic. Insurance is math. And the harder you make it for people who are moderately healthy and buying their own insurance to buy insurance, the fewer of them will buy it. And then we end up in a death spiral. So Republicans prioritized it. This governor would rather have hospitals and doctors getting 23 cents on the dollar and claim that everybody's covered so that our hospitals can't survive, our small clinics can't survive, and we move closer and closer to single payer. So when he talks about Minnesota Care Buy-In, which is his backup plan for everything, it is so that our hospitals will have lower quality, our doctors will have lower reimbursement, we will no longer be the place for healthcare innovation that we have historically been. And so the governor is not going to be very open to new ideas. We need a new governor. Frankly, we need Congress and the president to act, and we need them to act on the principle that states can make good decisions when it comes to healthcare regulation, and that individuals can make good choices given the opportunity. And yes, there needs to be a safety net, but it needs to be a safety net, not a lifelong plan for dependency. We will take care of the poor and the disabled, but we cannot keep spending the way we've been spending, folks. And if you listen to the Star Tribune, their number one concern is the number of people who are going to become uninsured. They raise no concerns at all about our $20 trillion debt. So Congress is going to need to act. We're going to have to make some tough decisions. But frankly, I will trust any Democrat in our legislature over the people in Washington who make the rules without any transparency. And okay, I did a pretty good run there. I'm going to just give you something to take home and think about. When we passed reinsurance, passed bipartisanly in the House and in the Senate, the governor agreed to it. And now we are waiting for permission from Washington to do the right thing. That's what's happened, folks. Our legislature, our governor, all moved forward on an idea that benefits Minnesotans, and we are waiting for permission from Washington. And that's at the heart of the problem of the Affordable Care Act.
Thanks, Michelle. Representative Gruenhagen, you're both a professional health insurance agent as well as a state representative. What, in your opinion, needs to occur to bring health insurance premiums and quality health plans back under control into the markets in Minnesota? And a follow-up question, do you feel the ACA has had a positive or negative impact on healthcare and insurance markets overall?
Well, the answer to the first question is we do need to increase competition. Just like you have multiple choices on your auto insurance or your property insurance, the more choices you have, the better the competition, and you'll increase quality and reduce costs. That's the first question. The second one, I'd like to hone in on the access part of that question. And, you know, I just want to reiterate, and some of it's been said already, but the government-run programs of Medicaid and Minnesota Care, they reimburse doctors and hospitals at about 23 to 26% of their costs, okay? This is going to have, and on top of that, government-run healthcare is growing at a rate that is not sustainable, all right? It's growing at multiple billions of dollars. Now, I'll give you one example. The ACA was originally predicted by the Congressional Budget Office to cost right around $900 billion for 10 years when it came out. Now the Obamacare, the ACA, according to the Congressional Budget Office, is projected to cost $2.7 trillion over the next 10 years. So you have to understand, government-run healthcare reimburses at a rate that doctors and hospitals lose money, and the second thing it does, it grows at a rate that is not sustainable. We have to reform it. Now, I'll give you a reference, and some of you have maybe read this, but in the Minneapolis Tribune, the CEO of the Mayo Clinic made a public statement that the Mayo Clinic was going to favor private insurance patients over government patients. That's just the first step to more and more doctors and hospitals refusing to accept government reimbursement rates. It's happening all across our country. So if we don't repeal Obamacare and turn it back to the states, you are going to see a two-tier healthcare system in this country. One for the rich and the privileged, and a second-rate one micromanaged by government bureaucrats and insurance bureaucrats for the rest of us. That's going to restrict access and decide what care and if you get care. That's what it's at stake. You know, this past week I just went to the doctor's office. I'm in perfect health, but he wanted to see me. No, just kidding. Had to go for a checkup. So I went. At least I got one laugh out of that. When I went into the clinic room, a nurse brought me in there, and I started looking under the desk and under the table that was there and into the corners. And she said, "What are you doing?" I said, "I'm looking for that government bureaucrat and that insurance bureaucrat that's going to decide what care and if I get care. I know they're in this room, and they're just invisible." And you know what her response was? I fight with them every day on the phone to get the care that the patients need. That's where we're at now. If we don't reform this, it's only going to get worse. And if you go with single payer, you're going to have invisible government bureaucrats and insurance bureaucrats deciding when, if, and how much health care you get. And the privileged, the rich and the privileged will get the health care they want. That's what's at stake, ladies and gentlemen, if we don't reform this system. Other than that, everything's rosy.
Representative Lunan, you indicated you're also a professional health insurance agent as well as a state representative. Given the dynamics that have recently occurred at the federal level with the GOP's inability to repeal the ACA, what impact do you feel this will have on Minnesota's ability to pass meaningful legislation that will positively impact the employer, insurer, and patient's ability to access affordable quality coverage and care?
Well, first of all, I think Representative Dean made a good point that regardless of what the federal government does, we need to move ahead. We need to create and facilitate consumers bringing the market back into healthcare. You can find out what something's going to be, what it's going to cost. There are 3 figures to every medical procedure, medication, or whatever it is. There's a bill for it rate, there's the insurance reimbursement rate, and there's a medical assistance reimbursement rate. Here's why single payer will not work. You can, in Minnesota, get an EpiPen for allergies, $758. You can get that same pen over in Europe from a single-payer country for $11. I was at a Senate hearing and we asked the representative for Big Pharma, how can that be? Which is it? Are you losing money on the 11% reimbursement rate that you're bidding with these countries and supplementing it? Or are you making money on that $11 and gouging incredibly? And they said, no, we lose money when we send things over to the other country. The billing rules are different there. We're able to recapture it here. When you go with a single payer plan, there isn't anybody else to cost shift to. I personally consider it insurance fraud when what something costs is predicated upon who's paying for it, not what the cost of the item or the procedure was. That's fraud. That's statutorily defined as fraud. Yet we put up with it. Senator Benson brought up a good point with the reinsurance, that what we've set up is for insurance companies, we put a cap on what their hurt can be for any one claim. What this should do, and I call out the insurance carriers on this, what that should do is allow insurance companies to go back and rate people as if they're healthy. Because as soon as the ACA came in and said there's no more underwriting, that allowed them to rate everyone as if they're sick so that they maintain the ability to pay their claims. There's 3 statutory requirements for insurance premium in Minnesota. 1, it has to be adequate. You have to be able to keep your promise and pay the claims. That's what allows the carriers to increase their premium so much. 2, it cannot be excessive. There should be a relationship between the risk you represent and the premium you pay, just like myself. And 3, they cannot discriminate. The rates cannot discriminate at all. Now, we're all over talking about what can the legislature do, and people talk about, well, insurance companies need to do this, and people talk about medical providers need to do this. No, it's the consumer. It's the consumer that needs to bring the market in and shop. I am living proof. You cannot pay somebody to exercise for you. You got to do it yourself. This is something where the consumers have to step up and go, how much is this going to cost, and stay in there. And you keep asking that question. One thing I think we as a legislature can do is facilitate making it easier to find out what those costs are. But short of that, it really falls on the general population to put in the work, which is the way it was prior to the mid-1980s, when everything was an indemnity contract.
Great, thanks very much. Well, this is an hour conversation, and we're 40 minutes into it. So from this point forward, what we'd like to have is questions from the audience. Does anybody have any comments or questions specifically for any of our audience that they would like to ask or make comment on?
Thank you. Great discussion, by the way. Question I have is for health insurance companies, which I've never been able to understand and no one's been able to answer for me, is it's my understanding that a health insurance company can only sell insurance within the state lines. You can't sell throughout the United States, which I don't understand why they're only allowed to sell within the specific state lines. I would think that when you don't want to have a single payer system and you want to have competition, that if you increase the pool of your participants, it's going to lower the cost. So I would think that if you could go throughout the United States, you'd have a larger pool, smaller costs. Thank you for your answer.
And I'll pass the mic here in a second. I think the general principle makes some intuitive sense, but each state regulates their insurance coverage, and it regulates it differently. Additionally, the way insurance products are structured now, you have a network. Usually you have a defined network. So if you wanted to buy a product out of the state of Wyoming, all of your in-network coverage would probably be in the state of Wyoming, and so it wouldn't make a lot of sense for you to buy that product as a Minnesotan. One of the things that we should look at and consider, what if you wanted to buy an Iowa product? Let's say you lived in Stillwater and you wanted to go to a doctor in Hudson, Wisconsin, and a Wisconsin product had that doctor in network. That could create some competition. It would be close to your home, so your network would make some sense. And so I don't think buying insurance nationwide is necessarily the panacea it's been made out to be. But I think in places like southeastern Minnesota, where you might want access outside the Mayo system to something in Iowa or southern Wisconsin, it might make some sense.
The crossing state lines, like the senator said, states are regulated at the state level, but the world is changing so much now. All insurance commissioners use the National Association of Insurance Commissioners website to gather data, harvest data, keep track of contracts, things like that. And so crossing state lines now is not problematic at all, and things that cause competition should be brought in. We talk about networks. I want to talk about just real briefly and quickly here, is that, again, the three stools of fair premium is adequate, not excessive, and not discriminatory. Well, the companies only owe reasonable, necessary costs to indemnify or to put you back to where you were pre-loss condition. Well, if I have an in-network doctor and I have an out-network doctor, and this is a bigger problem outstate, the insurance companies should only have to pay what they pay the network doctor. But the insurance companies don't want to do that. They want a punitive figure on her that no matter what the non-network doctor is charging, you have to pay 20%. Now, there are many instances where that non-network doctor has a lower rate than the network doctor. We're still going to penalize you for going out of bounds. As legislature, we should deal with that as well.
Any follow-up comment or question? Any other questions or comments anyone would like to make of our panel?
I was wondering. I lost my health care. It covers through my job. It'll be there 1 month, not another month. There's always a gap somewhere along the line. 2 gaps. I went to the doctor last month while I'm off coverage. Right now I'm paying out of pocket for my prescription. I paid them cash. Okay, normally it's $560 when they bill my insurance company. I paid them $150 cash out of my pocket. That was it. And then whatever for my prescription. So she told me there's a different rate. There's a cash rate. There's the rate for your insurance company, and then there's the billing rate of after that, like if they were going to bill me there. So why is that I can get it so much cheaper to pay out of my pocket? And then my follow-up question is that penalty on the state level for the tax, being taxed, having to take out my taxes because I don't have insurance, is that still there?
I believe the penalty is at the federal level. The question I have for you, and then I'll answer your question, is that when you went and you got that great deal, did you shop at all to find out if there was even better deal out there?
No, because it's a specialty clinic thing. So
Yep. Well, I would challenge you to to spend time online or whatever to do, just to make that little effort, even if you find out you can't get a better deal, but to get in that habit, to make that the culture, to compare the culture to shop, that's our first reflex, which we do in almost every other buying decision. The rules are in Minnesota are such that the carriers are allowed to do cost shifting. The billing rules are different. Now in statute, verbatim, it is fraud to attempt to collect for a figure other than what the cost of the loss was. Yet we have a wink-wink agreement that allows pharmacies, hospitals, doctors to charge different rates based on who is paying and where the money's coming from. And it's in this case you're winning, but it's confusing, isn't it? I had a situation where I had to go and get some tests done on my knee, and I went to the in-network lab, and it was $767. I said, I'll shop. So I got the blood work done at my chiropractor in my building. I had one of those little portable little bread trucks I could get an MRI on. I got it done for $178 instead of $767. Turned it into my insurance, no coverage, out of network. And that's how crazy it is.
And I'm with the union, so my insurance is out of New York, so I'm out of network anyway.
Oh, yeah. Yeah, just a follow-up comment to what Bob said. There is an organization of doctors and surgeons called the American Association of Physicians and Surgeons. It's a national organization. They have had meetings up here in Minnesota, and they're independent doctors that are not part of a healthcare network, and you pay them a monthly fee, and they will take care of your health care. That monthly fee is much lower than what the going through the insurance or government bureaucracy is. So medical professionals are taking it upon themselves to create a marketplace for people to get the care they need at an affordable price. I would encourage you to go to the website. It's called AAPS, and it's doctors all across the nation, and there's doctors right here in Minnesota that have participated. You know what the doctors refer to when they get out of these networks? They say we're out of the box of government and insurance, and we can actually practice medicine and care for our patients. So there are reforms going forward. Encourage you to research that. Again, we cannot continue down the path that we are on with the growth of government health care, with the demographic change, or you're going to look at a two-tier healthcare system, one for the rich and the privileged, another for the rest of us, micromanaged and rationed by government and insurance bureaucrats.
I want to comment too. The issue that you've uncovered is the issue called cost shifting. And if you are privately insured by your employer, you're covered by your employer, or you buy insurance you've bought yourself, you're going to pay more than anyone else. Which is why insurance keeps going up.
You can find doctors on the internet if you look at the wedge. That are private doctors who see people just like you who don't have insurance, and they've got the right price.
Okay.
I want to mention a little bit more about the wedge. WEDGE, the Citizens Council for Health Freedom. This concept is that the doctor will post his rates. The clinic will post what that test cost that Representative Lunan was looking for on his knee. That there will be competition in the market. And that's the idea. This is still, however, I wanted to mention about mental health because I'm a retired psychiatrist. One of the dangers in mental health is that with the network restrictions and the bureaucratic restrictions on the provider, the psychologist, psychiatrist, social worker, other people providing service is limited into how many sessions he can give, what codes he can submit to get paid. So the whole thing slows down, obviates, and cheapens the whole process of a doctor-patient relationship. And that's particularly important in addictions and mental health.
Just one more follow-up comment on your situation. I know somebody who wrote a book, Healthcare in Crisis, Is Government the Solution or the Problem? And it has a lot of those resources in it. I think the author is here today. Who is it? No, it's me. So in the back of the book, I don't know. So in the back of the book, I have a lot of these resources you can go to, including the American Association of Physicians and Surgeons. But do your research. There's healthcare out there. Again, the cost of government healthcare, right here in the state of Minnesota on MNsure. There was a MNsure board member who was quoted in the KSTP article. And we had spent over $200 million just on the website, no health care. $200 million just on the website and bureaucracy. Now we're at over $400 million. But at the time we had spent $200 million, a MNsure board member said, "What's the definition of madness?" Okay? And he was a CEO of a major company in this state, and he just threw up his hands. He's stepped off the board now. But you're spending $400 million just on the operation of MNsure. Nothing to do with getting you the health care. That's what you're going to see with single payer. Okay? Huge billions of dollars of bureaucracy and restricted access for your health care. We can solve this. But we have to understand government is the problem. It's not the solution. I hope I was clear on that.
Yeah. I had Minnesota Care up until December, which was just the last 2 years have been a complete disaster. But the median income, Dan, is 52. I'm kicked off. I can't afford your private plans. When you're talking, even with the government little handouts that they give me to lower it down, you're still talking $600 to $700 a month. I can't afford that. I can't afford to insure her. And my private plan that I have month to month here or there through my union, is out of network, doesn't cover her. Is there anything going to be done about that in the legislature? Because that pretty well dropped. I think it was 35,000. I think I have to really just not take work, or do I have to be a bum if I need health care?
Well, you've hit on one of the major problems, which is the availability of affordable health insurance. And if you're on Minnesota Care, you go on and you get a subsidized plan, about 92% subsidy, up to 200% of the federal poverty guideline. Then you just get booted off and you're on to the individual market. So younger people, they don't really have a choice. So if they go out into the market, if you're young and healthy, you're probably going to be the first person that doesn't purchase a plan. So the fact that we don't have availability of plans out there that people can buy at an affordable price is the problem. If you're no longer working and you're on COBRA, you don't realize that your boss probably was paying half of your costs until you're on COBRA, then you pay 100%, so you get the full whammy of it. And if you're a young person and you're trying to say, hey, I'm gonna be at the upper end of Minnesota Care, I'm gonna get a raise. You get a raise for $4 an hour, and that costs you $10,000 a year because it boots you out into the private market, and it creates this cliff that we have to look at. So if we've got a one-size-fits-all, top-down Soviet-style healthcare system that we have to buy, that's the problem. If we have products that we can shop for that actually meet people's needs, that's where we're going to have solutions. We need to have more products that you can choose from. That's the only way to get it affordable again.
Thanks, Matt. Mike, follow-up?
Yeah, just one follow-up that I'd like to make, and that's most government health care plans have a marriage penalty, okay? Obamacare, if you are a husband and wife, and this was put out by the Kaiser Foundation, not a conservative organization, if you have a husband and wife with 3 children and you earn about $110,000 a year, a little over that, and you get a $1 rate, you can $110,000, a husband and wife with 3 kids, you can qualify for a $9,600 subsidy under Obamacare to help you purchase health insurance if you were an entrepreneur or had a self-insure. If you got a $1 raise the next year, $1, you would lose the $9,600 in subsidy for health care, okay, under Obamacare. Your best economic decision would be to divorce your wife have her sign up for health care with the 3 kids, and they would get a subsidy, and you take out your own health insurance. It's just like the welfare system that rewards having children out of wedlock. So Obamacare is the welfare system coming into the middle class, and it undermines traditional marriage, which is the economic cornerstone of Western civilization. I could say more, but that's probably enough.
Just a comment to what you said when I went into one of their people.
Oh, no, here you
I went to one of their government insurance people over off of University in Fairview here, and the advice I was given, I've been married to this woman for 20 years, and the advice I was given by her, because I couldn't afford it, was one thing you could do is divorce your wife, and she can go on the system, and our 2 kids are just going into college, but they can be on the system, and she could have health insurance then. I was told that by one of their people.
I know. Another follow-up quick example, right? Because I sell health insurance. I had a young lady, about 27, 28 years old, a couple of years ago, come into my office, and she wanted health care. I gave her a quote, and she said, I don't know if I can afford that. I'm working a couple part-time jobs. I'm looking for a full-time job with benefits. So I suggested to her, well, why don't you go down to social services? They might be able to sign you up for a health care plan. She said, I've been down there. I make just a little bit too much money to qualify for Minnesota Care or government health care. But the social worker went on to tell her, if you would have a child out of wedlock, we could sign you up for all kinds of benefits, okay? Your government subsidizes illegitimacy. It has undermined and destroyed the minority family. On welfare system, the black family was less than 20% out of wedlock births prior to 1965. Today, it's over 74%, and the government subsidizes it. We have to reform this. We can reform it, and we can help these people move into the middle class rather than be trapped in poverty and broken families, which we know what that results crime-wise and otherwise in our society. And the government's the instigator.
Can I mention
And
one
Bob's
more
part
thing?
is
We talked a lot about the quality of our healthcare system, but we also had a very quality health plan system. We had a lot of innovation and a lot of competition between the health plans. There were great products being created, and the Affordable Care Act destroyed those because now they had to follow a specific government dictated plan. It had to be minimum essential benefits. There were mandates. There are things that have to be covered. You used to be able to buy kind of a limited benefit plan. You know, you could buy a short-term plan just to cover you in those gap months. And they were very inexpensive and easy to get. No more. Can't have those anymore. Everything has to follow the government plan. So that's another reason to get rid of the Affordable Care Act, bring innovation back to the health plans.
Okay, that's our hour. Let's hear it for our panel. All right, thanks very much.